This is Breakthroughs. I'm Erin Spain, your host and communications director at Feinberg. Millions of people are now living with COVID-19, and their long-term outcomes are unknown. Northwestern's Dr. Jeffrey Linder says more research studies on this group are needed to provide information about COVID-19 care before, during, and beyond the hospital. Dr. Linder recently wrote an editorial on this topic in the BMJ, and he joins us today to discuss. He is the Chief of General Internal Medicine and Geriatrics in the Department of Medicine at Northwestern and a primary care clinician investigator. Welcome back to the show, Dr. Linder.
Thank you so much for having me.
Before we jump into what you outline in the BMJ article, I want to talk about COVID-19 right now in Chicago, in the U.S., around the world. How are things looking in this first week of June?
This first week of June, things I would say are looking better. The date I've put in my own head for when I'm withholding optimism is June 10th, because that's about 2 weeks after Memorial Day, when we saw all those groups kind of get together. And then, of course, in the wake of the George Floyd protest marches, a little bit of concern about mixing of large groups, particularly in Chicago. So June 10th, maybe to June 14th or so, if things are looking good by then, I will at that point allow myself a little bit of optimism about the summer, that things will sort of peter along during the summertime at a lower level, and that we've kind of safely moved away from these peaks where we were really worried that our healthcare system, emergency departments, hospitals, ICUs would be overwhelmed.
I know that you are tweeting about this on Twitter, so I will be checking your stream on June 10th to see what you're thinking.
Right. Yeah. About every other day, just kind of checking with the numbers. The curve looks really good, but as we're seeing from some places around the world, there was a data from Iran today that it's here we are at the beginning of June. It's warm there, and they're having a kind of a second peak already. And I hope we're not in for the same here.
Well, let's talk about this editorial that you wrote in the BMJ. So in the first paragraph of this editorial, you said, without a vaccine or disappearance of the virus, we could be living with SARS-CoV-2 and COVID-19 for the foreseeable future, possibly years. How important is it that we prepare for that possibility?
Let me at the outset for the listener say, I hope I'm wrong. I would love nothing better than to be wrong, but the idea that we're going to quickly come up with a vaccine for a coronavirus, which we've never been able to do before in the course of 6 to 12 to even 18 months, just seems kind of unrealistic to me. Things may have changed. The technology is better. Our platforms for developing and producing vaccines is much better than it used to be. So again, I hope I'm wrong, but I think it's more likely that we're going to be living with COVID-19, managing it as it percolates through communities for the next couple years in the absence of a game-changing medicine or a vaccine.
What seems to be working to help support patients who are hospitalized with COVID-19 who are able to recover?
Because we don't have a clear cure, so there's one drug, remdesivir, that has the best data for it. And, it helps. It clearly helps for the right patients, but it's not a game-changing cure by any stretch of the imagination. So for patients in the hospital or patients at home, we keep hearing this phrase, supportive care. We need to do good supportive care. And I actually want to thank my co-author of this editorial, Dr. Alicia Rao of hospital medicine here at Northwestern. She really helped me sort of think through, what does that look like? What does good supportive care look like in the hospital? And it includes things like, of course, managing oxygenation, taking care of people's symptoms, making sure they're hydrated properly, managing their chronic conditions. One thing I'm very concerned about in my own research is the appropriate use of antibiotics. And so the proper use of antibiotics in hospitalized patients. So most patients with COVID-19 infection don't need antibiotics and can be taken off of them safely. We're very concerned about people developing clots. So clots in the leg that can break off, go to the lungs. So giving the right people anticoagulation, very close monitoring of our frail or immunocompromised patients. And then we've seen a fantastic collaboration between different specialties in the hospital. So hospital medicine, infectious diseases, pulmonary critical care, palliative care, and even ethics sometimes. Everybody kind of coming together and thinking through issues for patients with COVID. That's a lot of stuff. When you unpack good supportive care, there's a lot of things in there. And to go back to your question a second ago, in the absence of a cure, which I'm not that optimistic we're going to see real quickly, all of the components that I just outlined are critical, and getting those right and right for the right patients is what's actually going to improve people's survival and experience with a COVID-19 infection.
And establishing sort of this criteria for discharge and arranging the follow-up care for symptoms are really important. And, in this editorial, you talk about the need for more controlled studies of patients beyond those with the most severe form of the disease. Tell me about that and why it's so important that we now establish this criteria.
Yeah, I think now that the pandemic, we're still living with it, it's calmed down a little bit. So we have a little bit of an opportunity to continue to get organized, and talking about randomized controlled trials, not just the cures and vaccines. Those are important. People should be working very hard on those things too. So even though I'm a little pessimistic than most, trust me, I want all that work to continue in force. But at the same time, all of the things I just mentioned, symptom management and supportive care, fluid management, oxygenation, there's loads we can learn about the right way, the safest way, and the most effective way to kind of bring all these things to bear to take care of patients who might not be in the intensive care unit, might not be in a ventilator, and how can we prevent that from happening? And then taking even a step back, keep in mind that 80% of people who have the novel coronavirus infection don't need to be hospitalized. So people are home. Some people are minimally symptomatic. Some people are very symptomatic with an awful flu-like illness. Are there things we can do to be helping people take care of themselves at home, manage their symptoms, manage oxygenation at home, so they don't even need the emergency room. They don't even need to be hospitalized.
Well, and not everyone is recovering well from COVID-19. What are some of the issues you hear are facing those who are recovering?
Yeah, and here we're kind of really, I feel like we're in the land of anecdote, that because everybody has been rightly focused on very sick, intubated patients in the ICU, but most of those people survive, go home. Being in the ICU is just kind of awful. In my own training, I always heard this saw that being in the ICU for a week will age you like 5 to 10 years, and it's really hard to recover from. You've had a breathing tube in, you've been sedated. People are often strapped down to avoid pulling out lines and tubes. We overwhelm people with fluid that takes a long time to get off sometimes. And so recovering from that is not trivial. And recovering from that with an infection that's caused an overwhelming inflammatory reaction in people's lungs and in their other organs is no doubt going to take some time. And I think we're just beginning to see how long that's taking for some people. So anecdotal reports about people having prolonged symptoms that last for weeks or even months after a COVID-19 infection. And I think we're just kind of at the beginnings of understanding that. And in fact, got an email literally today from Dr. Buttinger, our division chief for pulmonary critical care, about starting to think about, hey, should we be setting up a special clinic for people recovering from a severe coronavirus infection? And so we're just at the beginnings of trying to maybe set that up, maybe learn what we can, and of course, take the best care of patients we can.
And there's still the threat of reinfection. We don't know if that's going to occur or not with this disease.
I don't want to be, I guess I do want to be a little dramatic here, but in my own mind, that's the horror movie scenario of this, of people who have recovered from coronavirus and you're immune for a couple of years, hopefully, but then could get infected again, like these 4 cold viruses that have been around forever. And we've all had them multiple times probably. But yeah, that really is kind of the horror movie scenario. I hope that doesn't come to pass.
Tell me right now, what is the guidance that you're giving for effective home care?
So we're running a home monitoring program for patients who have tested positive for COVID, who can take care of themselves at home. And as part of that program, we're having people fill out a daily questionnaire that asks about kind of the more severe symptoms. We're not asking about all the symptoms. We wanted this survey to be doable. So things like shortness of breath, chest pain, muscle aches, and the like. We're keeping an eye on whether people are developing concerning symptoms. So worsening shortness of breath, chest pain, confusion, or signs of poor oxygenation, like bluishness of the lips, or confusion can be one of these as well. we are doing our best to help people manage their symptoms at home, stay a little bit active, but there is no cure right now, which is frustrating. So it really is about home supportive care. So again, fluids, oxygenation, eating right, and then symptomatic management.
And about how many people are involved so far in this surveillance program?
We've had just shy of 7,500 people come through this home monitoring program. At our peak, we had about 1,500 people at our peak day. It's kind of petered down to just under 500 people a day. As you said, here we are at the beginning of June, and hopefully things are quieting down. And so we've seen the numbers go down by 15 or so each day the last few days. But it's been a tremendous effort on the part of Feinberg and Northwestern Medicine to kind of put this whole program together and monitor a huge number of people, the vast majority of whom do okay at home and don't need to go to the hospital.
Is there anything you can tell me so far preliminarily about what you found with this group?
So we have a lot of data on people right now in terms of having filled out these questionnaires, and our nurses, advanced care practitioners, medical students have been calling patients, so they've documented quite a lot about these patients. But again, literally today just got approval to kind of really dig into the data more deeply to try to understand, can we identify predictors of people doing badly, and is that prediction we would do going to be clinically useful? So that is to say, on a statistical basis, I'm sure we're going to find things that sort of make it a little bit more likely or a little less likely that you're going to have to go to the emergency room because you've developed worsening shortness of breath. But for an individual patient, is that worthwhile? And it seems like anecdotally, I'm a little skeptical too, because we've had stories over the past few months about people who have no risk factors for a severe course. So these are people who are not old, who are not immunosuppressed, not pregnant, not obese, who suddenly get a lot worse on, say, day 8 of their illness and need to go to the hospital and in some cases get intubated right away. So I hope we find some risk factors that are useful to us as clinicians, sort of who do we need to keep a closer eye on, and to patients to monitor themselves more closely, but more to come on that.
And tell me, have you been on campus much lately? Are you seeing patients? Just tell me a little bit about what it's been like for you over the past few months in your leadership role at Northwestern and seeing patients at the hospital.
So when the outbreak first happened, there was a big call for people to staff inpatient teaching teams to free up the hospitalists to work on dedicated COVID units. And so I did that right away, sort of went into the hospital just at the very beginning of the outbreak here in Illinois. Since then, I'll be honest, I've spent a lot of time, like most people, at home and delivering care over telemedicine. So using video, using phone, and doing a lot of coordination of the home monitoring program from home. So, as much as I've been in the thick of kind of directing and helping manage this home monitoring program, I think the credit for hard work, the day-to-day stuff really goes to our colleagues in the emergency department, in the hospital, and in the ICU. And we're just now starting to ramp up our clinic practices a little bit to start thinking about who should we have come in, how should we have people come in. But our in-person visit volume in our practice and then in primary care practices across Northwestern Medicine remains pretty low.
Is there anything else that you would like to add?
One thing I'd like to add is we still need to not get cocky with the way the numbers are looking in Illinois right now. So we mentioned before, I've tweeted about every other day, watching kind of the numbers come down. And we still are at the phase where we need to be practicing all the things we've learned to now: wear a mask outside, practice physical distancing from others outside of your household, wash your hands. And if you have symptoms, now we're in a place where get tested. So I think not as sexy as a cure or a vaccine, but these kind of public health measures to avoid the spread of coronavirus remain critical.
Well, thank you so much, Dr. Jeffrey Linder, for taking the time to talk with us today. And we're looking forward to what you're going to publish about the surveillance program.
Thanks for having me.
We will be taking a short summer hiatus from producing the Breakthroughs podcast. Please go into our archive and check out any episodes you may have missed. And subscribe to Perspectives, an essay podcast featuring members of the Feinberg community.